Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. A very warm welcome, everyone. My name is Vicky Cameron. I'm Deputy Dean here at the University of Otago, Christchurch, and a research professor with the Christchurch Heart Institute. I'm going to be your MC for this afternoon's celebrations of the Christchurch Heart Institute Heart Research Group Award. Research Group Award. We're dividing the afternoon into 4 sets of talks, each representing a decade that the group has been in existence, with 2 to 3 speakers presenting some research highlights from each decade. We've got a lot to fit in, and time is tight, so we won't be able to take questions after each of the talks, but I invite you all to stay around for afternoon tea afterwards, when you can save your questions for the speakers at that stage. Before each set of talks, I'm going to give a brief pictorial history of that decade to set the scene. So this will introduce you to the people rather than the science. Hopefully it'll be a lighter look. So let's get started, if I can get the technology to work. Let's get started with the 1980s. Right, we now have 3 talks from some of those Jedi Masters. First, we will hear from Emeritus Professor Gary Nichols, whose specialty is understanding the regulation of water and salt balance in the body. Then we're going to hear from Associate Professor Tim Yandel, whose special skill is setting up tests to measure blood levels of newly discovered hormones. And our third speaker is Emeritus Professor Eric Espiner, whose area of expertise is understanding the body's response to stress, including the effects of stress on the heart. Gary, would you like to kick off, please?
Good afternoon. I want to share with you an anecdote from 40 years ago, way before the natriuretic peptides were even thought of, and it's to do with the first administration of an ACE inhibitor in one of the first administrations in the world for a patient with severe heart failure. Heart failure, as you know, is a condition when the heart is insulted, for example, by a heart attack, and the remaining muscle struggles to provide adequate supply of essential components right throughout the body. And as the heart failure worsens, then the renin-angiotensin system is activated proportionally. So in severe heart failure, there's very high levels of angiotensin II circulating, formed by the enzyme ACE. Well, the story really begins with Bothrops gyrarica, this South American pit viper. Some very clever biochemists in the Squibb company in the United States worked out that the venom of this snake contained an ACE inhibitor, a substance that blocked ACE and therefore would drop angiotensin II levels in the blood and should open up the the little arterioles throughout the body. Based on that knowledge, two very smart biochemists in the Squibb company in the States synthesised a couple of drugs that should block this system. So this is about 1980, and Mr. J is in the wards with really terminal heart failure, most unwell, sitting in bed, panting, unable to eat, sweating, pale, very low blood pressure. We managed to persuade the Squibb company through the local company in Auckland to get one of these new drugs from America well before it was available for clinical use. And Mr. J agreed readily to take on this unknown drug for the first time. And enter Napoleon Hamadakram. Hamad's trying to persuade us that he was a close relative of Napoleon. But so Mr. J agreed to be a guinea pig for this new drug. Princess Margaret Hospital, sitting in a recovery bed just below the operating theatres, 1980 or so. Hamad put in the catheters by which we could see whether the response was good or bad from cardiac function and arterial pressure. And we gave the first dose of this drug, silence, and we watched. And after 10 or 15 minutes, the blood pressure started to fall. After 20 minutes, the blood pressure continued to fall from a very low baseline. And I can tell you our blood pressure started to fall. And I remember wondering where the nearest toilet was at that stage. But by 30 or 40 minutes, the pale skin became pink. His breathing clearly improved. And despite the low blood pressure, a big smile came across his face, and he said, "Geez." And it really was a marvellous moment that I suspect Hamad remembers very well. We continued the drug over the next 5 days. There's Mr. J. I don't think the colour is true there, but there's no doubt he was pink, whereas when he came in before the drug, he was just so pale it was unbelievable. As I say, this was a bed below the operating theatres at Princess Margaret Hospital. He continued on the drug after having his catheters removed, and a couple of weeks later he walked out of the hospital, which was just a miracle to us, and we followed him up in the outpatient department. And the rest is history, really. We studied 5 patients like Mr. J and published the results in the Lancet Medical Journal. And the rest is history, really. Big studies overseas showed that not only was there a clinical improvement of major magnitude, but longevity was increased as well. And that was captopril, and many prils followed later, and they've become standard treatment. So that was one of the early studies 40 years ago, and it brought together the whole team, as has been mentioned: dietitians, biochemists, lab technicians, biostatistician, biochemists, as well as the doctors. And we were very grateful to such patients as Mr. J. Thank you very much.
Yes, well, I'm going to really present results on 2 of the natriuretic pool hormones from the early days. These are atrial natriuretic peptide and B-type natriuretic peptide. They're both secreted by the heart, and they act on the kidney to induce a loss of sodium and water through the kidney and to reduce blood pressure. They belong to this small family. They belong to this small family of natriuretic peptides, which have the cyclic ring structure here. Now, in 1984, I began setting up an assay to measure ANP in the plasma of patients. It was a difficult task, but I succeeded after raising antibodies to the peptide and developing a method to extract and concentrate ANP from the plasma prior to assay. And then at the very beginning, we used the assay to measure the ANP concentrations in a number of subjects, and you can see that the circulating levels of ANP in normal healthy subjects, from our point of view, were reasonably low. In patients with heart failure, they were generally raised, and some of them markedly so. They were also raised in patients with renal failure and with Conn syndrome. So these studies really proved the worth of the assay, and it was later used for many studies in both the clinical and animal groups in our group. I used the assay myself in my own work to characterise the forms of ANP circulating in the blood of heart failure patients. And this slide shows the HbA1c separation of ANP peptides in plasma, and using the assay to detect the ANP coming out of our HbA1c column. This large peak here eluted at the position of ANP, but you can see that that peak was a relatively minor component of everything that was eluting off that column. So I then went ahead and extracted a large volume of plasma, purified the material substantially, and then put it back through the column, and then I sent these two major peaks down to Dunedin for amino acid sequencing to further identify what was in them. And the sequencing data that came back from Alan Kahn in Dunedin showed that the main peak there was in fact the complete ANP molecule, as we sort of expected, but in reality this was the first definitive identification of the main circulating form of ANP in humans. The smaller peak here was a metabolite of ANP, which we called cleaved ANP, because it was produced by cleavage at this point here in the ring structure of ANP by the enzyme neprilysin. Now, I don't have a lot of time to detail all the flow-on effects, but Chris Charles has shown that the cleaved ANP peptide is actually inactive biologically. So that means that one cleavage at this point here by neprilysin inactivates ANP. Following that, a number of drugs companies became interested and made inhibitors of neprilysin to block this degradation pathway. And Chris Charles will be further talking on this subject later on a study he's done using an inhibitor. I'll move on now to studies that we did with BNP peptides. BNP was first identified in 1988 and was subsequently shown to be synthesized in the heart by this long precursor, proBNP. And that precursor was cleaved at that point to give rise to the biologically active circulating form of ANP. So at that point I established an assay to measure BNP in plasma, and that actually underpinned a lot of the subsequent clinical studies that were done in the group. But I also used the assay to investigate what was happening with proBNP, and was able to show that in addition to it being present in the heart, it was also circulating in the plasma of patients with heart failure. And then, encouraged by that finding, we then looked for what happened to this amino terminal fragment of the proBNP molecule. So the question really was, did this fragment appear in to circulate in humans? Fortunately, we had Penny Hunt available to do that work for her MD thesis, and she raised antibodies to the amino terminal end of this putative peptide, which we called amino terminal proBNP. And then, she developed an assay to that fragment, and then having developed the assay, she then used HbA1c to separate the BNP-related peptides by on the column, and collected fractions, and then assayed those with the BNP assay. Now the BNP assay shows the initial peak that we usually got with proBNP eluting early, and the smaller biologically active peak coming in here. And we were predicting that if amino terminal proBNP circulated at all, we'd see a little peak somewhere in here. but I was in fact greatly surprised by this enormous peak of amino-terminal pro-BNP eluting at exactly the position that AMP should elute. So this was the first identification of amino-terminal pro-BNP present in the blood of any species. Penny then went on to measure the concentrations of amino-terminal pro-BNP in patients with heart failure and showed that they increased with increasing severity of heart failure. Not only that, but these levels, as Mark has already outlined, are massively greater than the amino-terminal pro-BNP concentrations in normal people. So that study really concluded that amino-terminal pro-BNP was an early early marker of cardiac dysfunction. So we were delighted to find this new peptide, but much work has been done since, and it had many outcomes. And from that, as Mark has already alluded to, studies by Mark and Richard Trausen have shown that the NT-proBNP assay can be used to diagnose heart failure. The NT-proBNP assays were then made available on big commercial automated analyzers by a company in Germany, and that spread the assay's diagnostic use worldwide. And finally, the amino-terminal proBNP is now strongly recommended for use in the diagnosis of heart failure on both American and European guidelines. And this study had a lot of collaborative work in it, and I'd like to acknowledge the significant input that both Gary Nichols and Eric F. Spinner have had in these studies.
As we've already heard from Mark and others, these first 10 years in the 80s through to 1990 were very exciting ones for the cardioendocrine group. And we studied a number of features that reflected the actions of these hormones, ANP and BNP, in normal people and in people with heart failure, and also the metabolism of those same hormones, and very importantly, as Tim has alluded to, the measurements of ANP and BNP in different cardiovascular disorders. So we were well advanced in our thinking by the end of the 1980, and we came up with this concept that if the heart suffered some injury or damage, then the ability to eject the right amount of blood into the circulation would be impaired, and there would be a build-up of intracardiac pressure. That increase in intracardiac pressure would lead to increased release of these cardiac hormones, remembering that the heart was not known as an endocrine gland until these times, and these hormones circulated in the blood to act on a number of different tissues. In fact, the tissues that maintain the health and integrity of a normal cardiovascular system. It led to the renal excretion of salt and water if the heart was overloaded, this increase in intracardiac pressure generating ANP and P. These hormones generated more excretion of salt and water, and they reduced the hormones that would normally lead to reabsorption of those same electrolytes. Not only that, these hormones opened up the resistance vessels so that the blood pressure would fall and take the strain off the heart. And thirdly, they would shift some fluid from the overloaded circulation plasma component into the interstitial space, further reducing the circulatory pressure, and in a classic endocrine negative feedback sense, reduce the initial problem, which was a build-up in cardiac pressure. Well, it doesn't take rocket science to think that the level of ANP and BNP might reflect intracardiac pressure. And I was thinking of just how we could make use of that. As a clinician, often faced with people admitted under my care with acute breathlessness, shortness of breath, they were gasping for breath and not being able to be sure whether this was because of lack of oxygenation or chronic obstructive airways disease, a very common problem, or was it due to heart failure? And in fact, we would peer at some length at the neck looking for engorged veins, and it was very difficult to see in a person who was labouring to get air and move their chest. we tried to find evidence of excess fluid, for instance, with any edema present, swelling at the ankle, or with the crackles at the lung bases. We were really guessing as to whether this was airways disease or heart failure. So I thought that was not a good situation to be in. We needed to have a test. And why wouldn't we measure BNP? If it was a marker of cardiac stress, surely that would distinguish heart failure from a person who was struggling to get air for another reason. So, fortunately, we had a very active medical student, Mark Davis, who's in the audience today, and we were able to initiate a study which led to the study of some 52 people admitted to the emergency room acutely breathless. The study would involve the normal treatment, best treatment possible for that condition, whether it was thought to be heart failure or airways disease, and I've said that was a bit of a guessing game. But the addition here was the measurement of BNP in a blood sample taken as soon as we could after the patient's admission, and again just prior to their discharge. And there was one other test that was added, and that was a measurement of cardiac performance using a nuclear medicine scan. That couldn't be done on the day of admission, but often a day or two later. In the event, we had 20 subjects that had primary lung disease, 12 that were thought to be heart failure, and 20 that had a mixed picture, both heart failure and lung disease. How did we determine that? Well, this was left to a panel of specialists who adjudicated the diagnosis after the fact. In other words, well after the patient had been discharged from hospital, and they would have all the evidence that the clinicians had. In addition, they would have the measurements of the X-ray and the final outcome, but they would have no knowledge of either the BNP level or the nuclear med scan result. So in that respect, it was an objective study. Well, what were the findings? We were delighted to see that, as the left panel shows, the subjects with primary lung disease did not have greatly elevated BNP levels. This vertical scale here, the Y scale, is a log scale, so you're getting up here to enormously high values. Just to give you perspective, the normal level of BNP is something like 5 picomoles per litre. So the subjects with heart failure, either pure and simple or mixed, as it was on the right here, had clearly elevated levels compared to those without a heart failure component. A better way of examining that involves a receiver-operator curve, which basically looks at the ability of one of these tests, be it the ANP measurement, the BNP measurement, or the scan measurement, to detect the signal. The signal here was an element of heart failure. And the measurement is shown here, either ANP or BNP. Now let's track down the BNP line. This is data of all 52 subjects thrown in. So if we travel down this curve, we see an inflection point for the BNP, which corresponds to 90% in that values that were higher than that for the BNP level in this acutely breathless person would represent heart failure. In other words, the signal here of heart failure was detected in 90% of the time if the level was raised. The obverse of that is to define what is the false positive from this. And at that very inflection point, there's 10% of people that had a high BNP but did not have heart failure. So they were the false positives. So putting all that together, we were confident we'd come up with a real advance here, that in subjects with severe breathlessness, the BNP level, the assay as measured then by radioimmunoassay, which took several days to measure, by the way, and that would assist in separating subjects that truly had a component of heart failure from other causes of severe breathlessness. And if that was so, it would open the door and enable much more effective, focused treatment. Well, we published that in the Lancet, and in no time we got correspondence to say, that's all very well, but by the time you got your BNP measurement, the patient was either dead or they had been discharged from hospital well and recovered. That was fair comment, but technology came to our rescue, and within a few years, because of partly our paper, and the recognition that BNP was registering intracardiac pressure. The new technology showed that BNP could be measured in a simple finger prick test within 15 minutes. So the patient admitted on the emergency ward could have that test available to the doctor, and they could decide whether that was heart failure or something else. And that was formally published about 8 years after our EPIC paper in the Lancet, in 200 subjects, and using amino-terminal proBNP as well as the point-of-care assay that has been alluded to. So I think we answered the question that this was a very valuable test. There's one other thing that we found from that study, and that was that if we looked at those subjects that had responded well to treatment, whether it was from airways treatments or treatment for presumed heart failure, there was an important finding that those that had the final diagnosis of an element of heart failure present, that the level fell from 82 to 36, a highly significant fall, within 7 days. There was no significant fall in the people that got the best treatment for presumed obstructive airways disease or primary lung disease, whatever it might be, but wasn't heart failure. There was a small fall that could be interesting to discuss. But this then tells us that BNP would be likely to reflect the efficiency of heart failure treatment. And I think that opens the door to what we'll hear further later in terms of guided treatment. So we summarise our findings by saying that BNP assays, even today, as Mark has alluded to, are officially recognised by the American Heart Association guidelines as a biomarker of choice for the diagnosis of heart failure. That's a Christchurch achievement. And since then, there's been widespread uptake of plasma BNP assays, thanks to Tim Yandel and the group in cardioendocrinology developing M&E assays. This has now been added to the traditional weaponry of imagery and measurements of intracardiac pressure beloved by cardiologists. I tell you, it took some time to convince cardiologists that a simple blood test might also be helpful. Thank you.